From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. The undersupply and geographic maldistribution of dermatologists in the United States has been very well documented. This has resulted in excessive wait times averaging 30 to 100 days or even more for clinic appointments. For patients with new skin lesions, especially those concerning for cancer, for example, long wait times can be associated with advanced disease at diagnosis, resulting in more aggressive treatment, resource utilization, and poor patient outcomes. In a new study in JAMA Dermatology, authors evaluate whether a rule-based triage system is associated with better skin cancer risk stratification of patients and reduced wait times. Dr. Albert Chiou is a clinical associate professor in the Department of Dermatology at Stanford University in Palo Alto, California. He is senior and corresponding author of this new study, and he is here to discuss this important work. Welcome to the podcast, Dr. Chiou.
Thanks, Dr. Adamson. Looking forward to talking about the study.
And I'm looking forward to talking about it as well. And also having you on this podcast. I have been an admirer of your work for a while. I know you do some stuff in artificial intelligence, like health services, research, a lot of different things. And so I was excited when I got to see this and you agreed upon the invitation to appear on the podcast.
Well, let me say that the feeling is mutual and just excited to talk about this because I know a lot of your research has touched upon similar topics as well.
So what is your role at Stanford? Do you have a role evaluating kind of quality improvement projects at Stanford, or was this kind of a project that came out of an experience you had maybe with patients or as a dermatologist in Palo Alto?
One of the main hats I wear is as a clinical trialist and clinical investigator. But I think a lot of that work inherently works with a lot of data, a lot of analytics. And so I think I've been drawn to some of our quality improvement efforts in the department that may have more of an analytical bent. So I think that's kind of how this project came about. But I think how I got pulled into it was more of a personal practice experience. I think like many of us, you sometimes get surprised by the new patients that show up, the new referrals that come in. And I think especially right around when we were coming back into normal operations after the COVID shutdown, we were, like many practices, working through a pretty large backlog of patients because we had such disrupted in-person services for a while. And actually, I had at least one particular case with a patient with a growing nodule who waited essentially 4 months to see me. And I just felt awful through the whole encounter because he basically mentioned that at the point of referral, he and the primary care doctor were already worried about this. But when they told him that the next available appointment was 4 months, he actually just kind of said, well, you guys told me it would be okay, so I just waited. And so I just kind of realized that in the referral system, patients feel like they're in our care already, and they're kind of taking our word for when it's quote unquote okay to come in. And since then, I've been involved a lot with working with our new patient coordinators, referrals system, and this really dovetailed nicely with my colleague, Dr. Justin Koh, who's our medical chief, was already working with the hospital to really try and get at the analytics to try and understand our patients. He's really interested in the whole concept of right patient at the right time with the right intervention. And so we were able to get some support from the hospital to really dig into our EHR and really try to ask some questions about our referrals process and if we can do better with it. So I think that's kind of how I got pulled in. He knew I was pretty motivated from some of these past cases, and it just dovetailed with getting some access to resources to do this study.
Right, and you have the research skills in order to try to answer some of these questions.
Yeah, I just want to mention really hats off to our first author, Dr. Yichen Chen, who's a biostats PhD. He's been instrumental in this, but yeah, it's been a great partnership.
And so when you first started thinking about designing this project, what kind of data were you looking to get? Were these just historical data? Were you going to collect data prospectively and see what happened over a year, 2-year period? How'd you go about, one, determining the problem, like how were patients referred to in the beginning, and then two, how you would actually set up this referral or triage system that may in fact be better and more responsive?
We were very interested in actually building a way to track our patients moving forward. so that we could actually just over time make gradual adjustments to our referrals process, and particularly the referral form, and actually be able to see if these incremental changes were working. And I think we immediately jumped to the single lesions, both because of these personal experiences of really wanting to get patients in who may have been waiting longer than anyone would really want. But I think it also just made sense to kind of build for the capacity to do this for all different types of complaints. One of the first things that we want to do is actually just get a sense of what types of patients are coming to the department. We couldn't even tell how many patients we had who were interested in skin checks versus coming in for particular lesions of concerns or for rashes. So this was kind of a fundamental building block for us. And so we want to build a reporting backbone moving forward where we could not only start to bucket the types of issues people want to come in with, but then get a sense of what their needs were so that we could kind of match it. Because as horrible as the pandemic was, it gave us new tools, right? New robust digital arms that we could take care of patients in different manners with. And of course, the traditional long-standing medical question, who needs to come in urgently? So one of the first steps we did was we built the reporting framework and we linked it to our referral form so that we can put in actual categories of what patients would come in for. And then after that, then we added in the risk factors and other layers to it. So now we have that built out for single lesions most robustly, but also patients interested in skin checks, rashes, other common complaints.
And when you refer to a referral form, so is this something that only PCPs or certain referring providers have? What about patients? Can patients themselves in their patient portal maybe send photos or requests for appointments given some new or concerning symptoms? How did you kind of balance those different ways in which patients can make it to our office?
Yeah, so starting off, this really was focused on our referring clinicians. And the main reason for that is that many of them are already in our electronic health record. We use the Epic system. And so we can actually customize an electronic referral form that can very nicely link over to reporting in the background. And so that's why we were able to essentially put different categories of visits and then just make an ask to the referring provider that, yes, you can send patients over to us, but give us a sense, give us a fighting chance of knowing what the patient's coming from. In the past, it would be free text that, as you know, could be very variable. And the folks reviewing it don't have as much clinical background sometimes. And so this is a way to really make it easier for folks to interpret this and escalate cases that needed more attention. We are really interested in getting patients to be able to fill this out as well. But it's, I think, a slightly different research question too, in that when a patient says they're concerned for melanoma, how does that affect the biopsy rate or the melanoma diagnosis rate compared to, say, when their primary care doctor is worried about a melanoma? I can tell you what's happening right now is that when patients call in to Stanford to make an appointment themselves for our practice, the patient coordinators actually pull up the same form that the referring providers have, and they walk them through and essentially complete it for the patients. So we've had some of that early information. We've been taking some initial looks at it, but I think that's going to be one of our next steps is to see, hey, is this as predictive? We'd love to use that information as well.
So you did all the background work in terms of building this referral platform within the EHR that clinicians can use. When did you actually turn it on? Was there one set date that it was turned on? Did you advertise to the referring clinicians that this was happening? Can you explain to the listeners what that process was like?
We did turn it on. So just in one fell swoop in the spring of 2021, we just flipped it on so that all new internal referrals coming into our department essentially funneled through this referral form. And then we basically made obsolete the existing referral form. We still take paper forms from external docs who really just are faxing something in, but this really constitutes the large proportion of our referrals. So it's really impacting most of the patients coming in through our door. You know, we're an academic medical center, so anytime you make a change to referrals process, it's pretty involved. We were lucky because this was done through kind of a population health focused program. So we had a lot of institutional support to walk us through this. But we went through multiple cycles with an EHR analyst to build the referral form to try to make sure there weren't any unanticipated consequences for it. And then actually took it through a couple levels of governance where people at the health center and health system would review it and make sure it wasn't too much of a burden on our primary care doctors and that we got the results that we were intending. And so one of the big things was we got as much information as we could, but we really limited to 3 clicks. Really, what is the reason the patient's coming in for in terms of broad categories? Give us at least one associated risk factor, or this was kind of our educational intervention. If you really had no reason why they were coming in for a skin check or a lesion check, you actually had to indicate that to make people think through this in the referral process and finally just submit. So that's kind of how we thought through this.
Yeah, I can imagine in the EHR era that we're in, death by 1,000 clicks, if you had something that was too onerous and complicated, you might actually end up with less referrals.
Absolutely.
And maybe no referrals from patients that actually really do need to be seen.
That's a huge consideration in putting this together, minimizing the burden at the point of referral.
So you designed this EHR quality improvement intervention, turned it on in the spring of 2021, and you basically studied what happened over time, over the next few years. And you compared it to the outcomes that patients had before you turned it on to look and see what were some key differences. Do you mind walking the listeners through what you found? What were some of the major, 1, outcomes you were concerned about, and 2, how they shook out as a result of the rollout of this new intervention?
One of the main outcomes that we were interested in looking at is that compared to patients before the intervention happened, and also compared to folks coming in for different categories of reasons, how did the percentage of biopsies in each group change? And also, of those biopsies, what proportion of them ended up showing a malignancy? And a separate related outcome was what proportion of them turned out to be melanoma diagnoses, whether it was melanoma in situ or invasive melanoma. So this was an observational study, so we were a little bit limited. The folks that we looked with retrospectively, so before the intervention was turned on, we were able to go back about 5 years. Many of them, we didn't exactly know what their reason for visit was at that point. And as a result, we can have aggregate results there. We know that on average, about 10% of them got a skin biopsy. And of those skin biopsies, about 30% of them turned out to be skin cancer. And then 2.5% of the biopsies were actually melanomas. What's really interesting now is that now we actually know at the point of referral what the intention was for different groups of patients to come in. We could see how those statistics could change over time. And I think we were really pleased to see that there were pretty significant differences across the different groups. We were very much focused on single lesion patients for this particular part of the work because these are folks you already know just intuitively you want to do something differently about, right? If someone calls in and says, oh my gosh, I'm really worried about this patient with a melanoma, that's like, call to action right away. So the associated risk factors we put in for the single lesions are a lot of these common sense ones. Was it concerning to the primary care doctor that a lesion might have been a skin cancer? Was the lesion bleeding or rapidly evolving? Or does the provider think it's a melanoma? We also included other categories like, is it just being referred because it's symptomatic, itching or painful? Or you could also just indicate there was no reason why it was being referred. And frankly, we were really interested in what happened to the folks who came in with primary care doctor indicating their concern for skin cancer, bleeding or rapid evolution, or concern for melanoma, because those are the risk factors we as dermatologists would just naturally act on if we knew that was coming with the referrals. And, just thinking back to my patient, the nodule, many times primary care doctors indicate that, or other referring docs indicate this, but sometimes they don't. And then you totally lose that insight and that clinical intuition. So we kind of forced that into the referral form. And so we really closely tracked patients with these quote unquote red flag risk factors. And what we saw is that among those 3 groups, concern for skin cancer, rapid evolution, bleeding, or concern for melanoma, about a quarter of them were undergoing biopsies when they came into the clinic. And depending on the complaint, the likelihood of one of those biopsies being malignant was up to 50% or close to 50% if the primary care doctor is indicating concern for skin cancer. So I think it really showed that we could actually figure out who's really likely to get biopsies, who's high risk for malignancy diagnoses, and we could do something about it. That brought in the next phase of it, which is to very quickly expedite those patients into clinic.
And were you able to reduce wait times with this new triage system versus the old system that you had?
Yes, I think that was probably one of the big outcomes in addition to the changes in the biopsy and malignancy rates was that for patients who had one of these red flag associated risk factors, we were able to reduce their time to clinic by about a month. So that I think was something that we were really excited about, but we're still not quite where we want to be. So right now they're still getting in at least about 60 days or so. I think in some cases, if we get a lot more clinical information, you're going to have folks that are being pulled in way sooner, just getting squeezed in. But now that we finally know which patients are more likely to have a biopsy and the diagnosis of skin cancer, we're actually trying to build the capacity now to really receive those patients now that we know the different groups that are at higher risk.
And so moving forward, do you plan on expanding this to perhaps some other institutions that may also have Epic as their operating system? Do you plan or hope to have other places replicate this work?
I think we'd love to, though I think it's almost like once you have the visibility into your own system, you really want to make sure that your particular system and your patient population is doing as best as possible on it. So I have to admit, after we got these results, it's been all hands on deck working with a lot of my colleagues to develop urgent access clinic, lesion focused clinics to really drive down the time to clinic, knowing that some of these patients of certain risk categories that are very likely going to need a biopsy pretty soon. So that's been our main priority, but we would love to be able to bring this to other systems as well to see how this changes with different patient populations. I would add one more factor too, is to actually see how these characteristics change over time as well, because this is really our snapshot in time with the early intervention. But we would love to see if these different risk groups and which ones we choose to prioritize kind of hold weight as we move forward in time as well.
And I would say that what you're prioritizing also in this system is skin cancers. Do you think that there is a potential for crowding out other patients that may not be as high risk of having a skin cancer and may in fact have a skin cancer, but they just don't have 50 moles, all of these other risk factors, or they have really debilitating rashes that go underdiagnosed or undertreated? Was there any concern about equity here?
Yeah, there's a lot. And I think this is what makes this type of intervention so challenging, but also makes it so important to monitor how things are going once you put it in place. At the end of the day, this is giving you information to make triage decisions. And for every group that you help, you have to move someone back because we're working on the capacity piece, but at its purest, when you're just working with a constrained set of resources, someone has to get deprioritized for someone to get prioritized. One of the things that we have been seeing is that the folks who essentially are waiting longer to get these concerning lesions in are the folks coming in for asymptomatic skin checks. Some of these patients coming in for asymptomatic skin checks do have risk factors for skin cancer that are classically described in literature, like personal history of skin cancer, atypical nevi or more than 40 nevi. We actually ask for this information, and we are seeing that some of these groups have higher biopsy rates than the all-comers coming into our department. So I think we are thinking through if there are other groups, such as patients requesting skin checks that need to get moved up, and trying to take a rational approach to which ones. The rash point is a really good one too. That was actually going in our biggest concern, is that we would really prioritize lesional dermatology and the folks with rashes would suffer. We had quite a surprising result, is that actually with the course of this intervention, patients with rashes actually got in a little bit faster than they did before the intervention. And there's potentially a couple reasons for that, but I think the main one is that we really made it easy for primary care doctors to signal concern and intention about their referrals. And that did carry over to rashes too. We actually asked if rashes are affecting people's general activities of daily living or if it's generalized. And I think our new patient referral coordinators found that more interpretable. So I think just by going about this whole process, there was a little bit more engagement in terms of clinical escalations because folks found the information more actionable on their part, even if we didn't build a formal intervention around the rashes.
Albert, what would you want clinicians or our listeners to take away from the study that you did?
I think the takeaway that I'd want to convey is that there can be fairly straightforward adjustments that can be made to the referral process that can potentially have a pretty noticeable impact in helping to identify which patients are higher risk to have skin cancer or more frequent procedures. And that if you get that information, even a really simple rules-based intervention, at least in our study, was associated with pretty significant reduction in time to clinic for some of these groups that we were really worried about or really cared about. So depending on a practice's priorities, and it can be different depending on each individual practice, I think this could be something that could be done to really improve the triage process.
I'm Dr. Adewole Adamson, and I've been speaking with Dr. Albert Chiou about a rules-based triage system to improve access for patients with concerning lesions. You can find a link to this paper in this episode's description. This episode was produced by Daniel Masisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.